Okay, ladies and gentlemen, please take your seats, slightly delayed, but most of the delegates have been able to register. So, good afternoon and welcome, ladies and gentlemen, honored guests, distinguished colleagues. My name is Ralph Harlid, and I'm the president of the International Network of Health Promoting Hospitals and Health Services. I have the pleasure of chairing this opening ceremony together with my distinguished colleague, Professor Katsunori Kondo, whom I will introduce a little bit more in a minute. But I would first like to give you some introductory words of my own. It is a true honor for me, as president of the HPH network, to welcome you to the 30th International Conference on Health Promoting Hospitals and Health Services, a milestone year for the HPH network. And it's only fitting that we gather here in Hiroshima, a city that not only carries profound historical significance, but also represents resilience, hope, and a commitment to peace, values deeply tied to our mission in health promotion. This year's conference theme, the contribution of health promoting hospitals and health services to health equity, addresses a critical and timely issue. With health disparities affecting populations worldwide, we are called to ask, how can hospitals and health services serve as true agents of equity? How can we ensure that every person, regardless of their background, has a fair chance at health and well-being? Today, we aim to answer these questions by drawing from the principles that have shaped HPH legacy over 3 decades, aligned closely with the WHO's Ottawa Charter and the United Nations Sustainable Development Goals. Our discussions will build upon recent advances such as the WHO's Geneva Charter for Wellbeing and the Health Inequality Data Repository. Together, we will explore strategies and innovation that can promote health equity, particularly focusing on vulnerable communities from local to global levels. In our time here, we'll dive into topics ranging from enhancing access to health care or underserved populations, exploring the impact of environmental and social factors, to addressing the effects of conflicts, pandemics, and climate challenges on health equity. We'll also look at how HPH standards, organizational health literacy, and community partnerships can drive transformative, equitable health policies. As we begin this conference, I invite each of you to engage in these critical conversations with the intent to leave inspired and equipped with an actionable insight for advancing health equity in your own setting. Let us work together to foster a more inclusive, just, and healthier world. And thank you. With that, I thank you and wish you a warm welcome to Hiroshima. And now I would like to introduce, I'll leave the floor to Professor Kondo.
Then we will welcome the next speaker, Sarah Baba, WHO Director of the WHO Kobe Center. She will make an address at this memorable 30th International Conference. Sarah, Please.
Thank you, Professor Kondo. Distinguished guests and colleagues, I'm delighted to be the first to welcome you to the 30th International Conference on Health Promoting Hospitals and Health Services. A very special thanks to our esteemed hosts, the Japan Health Promoting Hospital Network, for hosting this important event in the historic city of Hiroshima, a city that creates a sense of both amazement and humility. And this year's conference theme, I agree, with a focus on healthcare and innovation for equity, couldn't be more fitting and timely. We can celebrate our shared global commitments to the WHO's Ottawa Charter and the UN Sustainable Development Goals, emphasizing equity as a precondition to all to achieve their full health potential, resulting in longer life expectancies that we can now see across the globe. At the same time, the threats to health equity are real. In Japan, we can see the resilience that the country and its people have demonstrated in the face of natural disasters, including the 2011 Great Tohoku earthquake and tsunami that claimed the lives of more than 16,000 people. In Kobe, I participate annually in the commemoration of some 6,000 lives lost during the Great Hanshin Awaji earthquake in 1995. Most lives are saved or lost in the immediate aftermath of a disaster. The tragedy of a disaster is compounded when health facilities or its functions are disrupted. Lives that depend on emergency care can be lost, and disproportionately so among the poorest and older adults. People count on hospitals to respond swiftly and efficiently as the backbone of support. Innovations are critical in preparing hospitals to manage emergencies safely and efficiently, and this is becoming an urgent priority as climate change brings more frequent and more extreme severe weather events. This means that our ability to come together like this and discuss these challenges is more important than ever. My congratulations to the organizers who has successfully brought together all of you with expertise, dedication, commitment to health and social welfare. Over the next 3 days, we have the unique opportunity to share successes, learn from each other, and forge connections. And under our global commitments to the WHO's Ottawa Charter and the SDGs, we carry the collective responsibility to translate this knowledge into action in realizing these commitments to equity. As described so eloquently by the late Professor Hirofumi Uzawa, social common capital can be the fundamental premise for equity in health and hospital services. Let's make the most of this opportunity. Thank you.
Thank you very much. And I would like to ask Professor Katsunori Kondo, from the CEO of the Japan HPH Network, to say some welcoming words. Please.
Welcome to Japan. It's my great pleasure to host the 30th International Conference on HPH, Health Promoting Hospitals and Health Services in Japan. Japan has a unique culture. I hope you will enjoy sushi, matcha, a punctual train, and other Japanese culture. In Japanese culture, rather than being proud of the bright side of ourselves, we focused on challenges. It is common for Japanese people saying our works are not enough yet. However, while preparing for this conference, I find or rediscover the bright aspect of Japanese society. Now, Japan has an average life expectancy of 84 years and a healthy life expectancy of 74 years. Both are the highest in the world. As healthy aging has been a dream for humanity since ancient times, it means that from the perspectives of the ancient people, Japan is a dream-like country. In the 1950s, after World War II, the average life expectancy in Japan was about 60 years, which is shorter than Western countries. It should not be overlooked that universal health coverage was introduced in 1961 in Japan to ensure all people access to advanced medical technology. At the time of the introduction, there was a shortage of doctors and healthcare institutions. The situation was described as insurance without healthcare. Many rural and underserved urban areas had no accessible medical facilities despite paying insurance premiums. In these underserved regions, people called for medical institutions, raised funds, and many healthcare professionals responded. In the spring, we asked Nihon Hidankyo, Japan Confederation of Atomic and Hydrogen Bomb Sufferers Organization. Then Ms. Kodama will make a speech at this opening ceremony. 1 month ago, it was announced that the Nobel Peace Prize would be awarded to the Hidankyo. We would like to express our respect for their efforts to realize the world without nuclear weapons through tireless grassroots movement. Health promotion is defined as the process of enabling people to gain control over and improve their health and its determinants. Now, I am proud that Japan has become one of the world's leading countries in the field of health promotion through its many efforts to realize universal health coverage and protect peace. However, Japan, like many other countries, still face disparities in healthcare access and significant health inequality that cannot be ignored. So, our works are not enough yet. Both WHO and the Japanese government and society are working toward reducing health inequality. Therefore, the theme for this conference is the contribution of health-promoting hospitals and health services to health equity. Together with all participants, we hope this conference will be a success, providing an opportunity to draw lessons from the experience of Japan and the world, and to consider what needed to be done to advance health promotion further. Thank you.
Thank you very much, Professor Kondo. And now I would like to ask Norio Shimanouchi, President of the Japanese Organizing Committee. I think we are all grateful to this organizing committee. They have done a tremendous job. Welcome.
Good afternoon, everyone. As the president of the 30th International Conference on Health Promoting Hospital and Health Services, I would like to say a few words on this occasion. Thank you for your attending this conference. That marks an important milestone of the global HPH network. Now, we are organizing the 30th International HPH Conference in Hiroshima. By the Japan HPH network, the reason is that Japan has experienced devastation caused by nuclear weapon in Hiroshima in the past. And at the time, peace has become as essential prerequisite for health. This conference will serve as a reminder of the importance of peace as an indispensable prediction for health, and thus of our collective responsibility to maintain this fundamental prerequisite not only of health but of life, echoing the principle of human right. I remember the words of Dr. Ilona Kikbush, WHO Regional Office for Europe, when I met her while studying at the University of Copenhagen, Denmark, in 1986. She said, "Our greatest enemy is poverty. The greatest target is peace." This is the second time in Asia and the International HPH Conference has been held in Japan after the 20th conference in Taiwan in 2012. In Japan, the Japan HPH network was organized in 2015 and is now in its 9th year. I served as the first CEO. In addition, public health at the University of Sydney. Professor Don Natbim has been appointed as special advisor. In fact, I am also serving as a special advisor after serving as CEO. As the theme of the 30th International Conference is health equity. Finally, building on the experience of 30 years of International HPH Conference, I would like to discuss how HPH networks on regional, national, and international levels have supported both social development on healthy justice, including universal health care, directive for range of physical and mental health care, and the promotion of global health as an important aspect of justice and equity at this conference. In any case, I expect that the 30th International HPH Conference will be an excellent ground for all participants to argue all these issues and 3 days of discussing and staying in Hiroshima. Thank you very much.
Thank you very much. And now we are hoping to get in touch with a speaker online. I would welcome Christina Dietscher, the chair of the scientific committee and head of department at an Austria Ministry of Health, to say a few opening words. I know Christina would have so much liked to be here, but sometimes you don't decide, others do for you. So welcome, Christina.
Honored guests, colleagues and friends, as Ralph Harlett just said, much as I would have liked to be with you on site today, I'm thankful that modern technology allows me to send you my words as well across the distance from Europe in my function as chair of the scientific committee of this conference. The International Conference of Health Promoting Hospitals and Health Services in 2024 is a historic event. It celebrates the 30th conference of the HPH network, and it is the second conference in Asia where HPH is a growing movement in numerous countries, currently 6 national regions and 37 organizations. In a time of increased global insecurity, multiple crises, the program of the conference focuses on the contributions of health-promoting hospitals and services to health equity as one of the main principles of the consortium, a topic that seems more than ever. By that, the conference relates to WHO's other to the UN Sustainable Development, the WHO Geneva Charter for in 2021 and Health Inequality Data 2023. Against this background, the conference aims to explore five main areas, each of which will be subject to a panel discussion. A general reflection on the important activity for the role of healthcare in equity will be the topic of plenary. This will be followed by the organizational level in plenary 3. Plenary 3 will then focus on health equity in specific groups of population. Plenary 4 will focus on contributions to health equity communities. And we will expand the on the role of the HPH network in promoting equity beyond the health sector, following the Ottawa Charter's principle of channels between the health sector, broader political, economic, and physical environment. We are happy that this topic has a lot of interest in the HPH community and beyond. This is well reflected in the over 800 registrations from 33 countries. The plenary program with speakers from around the globe, over 500 papers. I'm sure the program will be rich in covering a huge variety of research to policy. The event takes place in the historic of Hiroshima, which is an eternal memorial for the important peace in our world. It is a wonderful that this year Nobel Prize was awarded to Nihon Hidaki, and you just heard from Professor. And we are happy to have of this organization. On behalf of the scientific community, I would like to express my sincere thanks to our host, Japan Network of Health Services, and the Japanese Organizing Committee, especially to Professor Kondo, coach scientific committee of the conference, and to Ms. Fukuna for their tremendous effort here. Then thanks, of course, to the committee for several hundred for advising the development program. Thanks to all organizers and co-organizers. Thanks to all present speakers in oral sessions and to the poster presenters and the people who will be there for the session. Thanks, of course, to the organizing committee in Hiroshima and to the team and of the international conference in Hiroshima. And thanks to all of you being here with us for your interest in supporting HPH around the globe. I wish you many interesting, fruitful discussions, many new acquaintances, and many impulses for your activities around health promoting and health services. Thank you.
The next speaker is special guest suitable for this 30th conference held in Hiroshima. We are honored to welcome Ms. Michiko Kodama, Deputy Secretary General of the Japan Confederation of Atomic and Hydrogen Bomb Sufferers Organizations, Nihon Hidankyo, the recipient of the 2024 Nobel Peace Prize. As a Hibakusha, Michiko Kodama's testimony and advocacy have been instrumental in the global movement toward nuclear disarmament. So, Now we welcome Kodama.
ただいまご紹介いただきました日本被団協の児玉美智子です。
ちょっとお待ちください。ちょっとお待ちください。スライドが
まだ出てない。
もう一度お願いいたします。
世界で初めて原子爆弾が投下された被爆地広島へようこそおいでくださいました。今皆様がいらっしゃるここは極楽さんがあったとてもにぎやかな町でした。一瞬にして人も町も消え、死体と瓦礫に変わりました。歳月を重ね、今は死者の無念を思い、原爆被害は受忍できない、再び被爆者を作るなと訴え、戦争も核兵器もない世界の平和を願う祈りの講演となりました。1945年8月6日、広島、9日、長崎に投下された原子爆弾は、瞬時に多くの命を無残に奪いました。私はここ広島で被爆しました。当時7歳で国民学校2年生、木造校舎の中に、教室の中にいました。突然ものすごい光と爆風、教室の窓ガラスが鋭利に割れ飛び散り、教室の壁、机、床に、そして私にも刺さりましたが、幸いガラスが刺さっただけの軽傷でした。迎えに来てくれた父の背中におぶさり、帰宅する途中、この世の地獄を目にしました。皮膚が焼けただれ、ぶら下がっている人、真っ黒い炭のようになった赤ちゃんを抱いたひどいやけどを負ったお母さん、眼球が飛び出している人、飛び出した内臓を抱えて生きる人、逃げ惑っていました。水をください、水を、水をと、父は私にすがりついてくる人、その人たちをどうすることもできず、自宅に急ぎました。助けを求めるその中に、焼けただれ、口も聞けないほどの女の子がたった一人で、助けて、水を、と目で訴え、助けを求めるその目が今も私の目に突き刺さって離れません。声をかけることも水をあげることも何もできなかったのです。その子のそばを通り過ぎ、気になるので振り返ってみますと倒れ込んでいました。その姿を思い出すととてもつらいです。広島に原爆が投下された原子爆弾は B29 戦闘機エロナゲイからリトルボーイウラン型原子爆弾が地上600メートルの 上空で炸裂し、放射能と強力な熱線、爆風、衝撃波が広島の町を一瞬にして覆い、破壊しました。私はこの日、命を奪われているはずでした。それは原爆投下の少し前まで私の家は爆心地近くにあり、爆心地から350メートルの本科小学校に、今小学校と言います、国民学校、当時国民学校と言ってました。本科国民学校に通学していましたが、転校し、学校も変わりました。転居していなければ、家族も私も生きてはいなかったでしょう。その学校に通学していた児童生徒約400人、先生11人は一瞬のうちに焼き殺され、骨も見つからない状態だったと後で聞きました。爆心地から 3.5km 余りに転居した我が家も、爆風で2階の屋根が飛ばされ、ガラスが飛び散り、放射能を多量に含んだ黒い雨が家の中まで降り、壁やタンスにはいつまでも黒い雨の筋が残っていました。そんな我が家に親戚の人が何人も身を寄せてきました。その中に私の大好きだったいとこのお姉ちゃんもいました。お姉ちゃんはその日、学校に行く日ではなく、爆心地から500メートルぐらいのところの外の作業の日だったそうです。うちに来たとき、人間の姿とは思えない怖いような姿でした。顔半分、背中から足までずるずるに焼けただれ、ただれたところは化膿が広がり、体液が出ていました。そこに氏が這い回ります。大好きなお姉ちゃんの氏を取り、体液を拭いてやる、それぐらいのことしかできませんでした。声もだんだん小さくなり、うちに来て3日目の朝だったと思います。私の小さな腕の中で息を引き取りました。女学生で14歳でした。10歳だったいとこは軽症でしたが、下痢が続いていました。9月の初め頃のある日、鼻から出血し、口からは血の塊のようなものをたくさん吐き出し、突然亡くなりました。これが放射能の怖さでした。外見は何ともなくても、体の中で遺伝子が、染色体が壊され、命を奪われました。髪の毛がバサッと抜け落ちた人、顔から全身に死斑が現れた人、下痢を繰り返し血を吐く人、何人もの人が次々と亡くなっていきました。人々はうつるなどと言い、怖がりました。奇跡的に生き延びた被爆者は、自分だけが生き残ったという罪悪感、脳裏に焼き付いたままの地獄の光景、音、声、匂いを抱きながら、その後の生活苦、世間の偏見差別も経験しました。被爆者の苦しみは深く、今なお続くものです。79年経った今でも、 あの日が消えることはありません。原爆は人間として当たり前の日常生活を根こそぎ奪いました。それから何年か経って、母も父もがんで亡くなり、娘は2010年11月に突然がんに襲われ、12月に13時間にわたる辛い手術をしました。2011年2月発症から4ヶ月で行ってしまいました。明るい元気な子でした。亡くなって13年が経ちましたが、今も私のそばにいます。この子を授かったとき、被爆者の子として育てる中で放射能の影響が出るのかと迷いました。決断して産み育てた娘を亡くして悲しみと悔しさの日々です。そして2017年7月、核兵器禁止条約が採択されたその年の10月に、末の弟が多発性骨髄腫で逝きました。12月には被爆の時5歳だった弟が多重がんで亡くなりました。2人の弟の命を原爆は次々と奪いました。悔しさと寂しさで、次は私が行くのかと思う日々です。私たち被爆者は、このような地獄の苦しみを世界の誰にも味わわせてはならないと、再び被爆者を作るな、核戦争を起こすな、核兵器なくせと、国の内外に原爆被害の実相を語り、訴え続けています。原爆が投下され1ヶ月後、被爆者にとって最も援護が必要だった時期に、アメリカの原爆調査団を率いたトーマス・ファーレルは9月6日、海外特派員に原爆放射能の後遺症はありえない。すでに広島、長崎で死ぬべき者は死んでしまい、9月中旬において原爆放射能のために苦しんでいる者は皆無であると言明しました。原爆に関する報道は厳重に監視が行われ、原爆被害を隠蔽しました。原爆被害の事実を世界に知らせないため、プレスコードを発令し、報道統制を行いました。海外の報道関係もすべてマッカーサー司令部の検閲のものでしか、原爆に関する報道はできなかったのです。日本政府は被爆者に沈黙を強いました。原爆被害を隠蔽し、苦しんでいる被爆者に何の援助もせず放置し、見捨てました。住むところも食べるものもなく、体も心も病んで、働くこともできずに、多くの被爆者は亡くなっていきました。被爆者はアメリカ政府と日本政府に11年間見捨てられ、放置されたのです。放置された被爆者は1954年 ビキニ水爆実験被災後に原水爆禁止運動が全国に広がり、その運動に支えられ、自らも立ち上がり、被爆後11年目の1956年8月10日、日本原水爆被害者団体協議会、日本被団協を結成しました。結成大会で、自らを救うとともに、自らの体験を通して人類の危機を救おうと決意を誓い合い、再び被爆者を作るな、核兵器なくせと、結成から68年、原爆被害の実相を涙しながら国の内外に訴え続けてきました。核兵器は二度と世界のどこにも使ってはならない兵器だと、国際会議、国連で各国政府代表や国の内外で語り伝えています。私たち被爆者にはもう残された時間は多くありません。被爆者の声を、願いを一人でも多くの方に伝え、核兵器の非人道性を訴えてください。今、核兵器をめぐる世界の情勢は極めて厳しい状況にあります。もし核兵器が意図的であれ、偶発的であれ、再び使われることがあれば、未来に甚大な被害を及びます。ここに今日お集まりの皆さんが核被害者になるかもしれません。戦争も核兵器もない世界を求め、ご一緒に声を出し歩み続けましょう。原爆の被害は過去のことではありません。現在、未来のことです。私は死ぬまで被爆者です。被爆者から逃れることができないのです。核兵器禁止条約は国際法として世界の歴史に刻まれました。しかし、地球上には12100を超える核弾頭が存在しています。核兵器があるということは、明日にでも広島、長崎のあの惨禍が繰り返されるということです。と同時に、今世界を揺るがしている戦争は、未来ある子どもたちの命を奪い、核兵器使用も辞さないと威嚇しています。何のための、誰のための戦いでしょうか。核兵器保有の主要5カ国は、核戦争に勝者はいないと宣言しました。しかし、核兵器国とその同盟国が禁止条約に賛同していないことが残念でなりません。特に唯一の戦争被爆国の日本政府がいまだに承認も批准もしていないことに、被爆者として怒りと悔しさでいっぱいです。皆さん、核兵器が地球上にあること、それ自体が人道的に許されるものではありません。青い地球を守るのか、破滅の道を選ぶのか、今岐路にいます。私も被爆者の一人として、 原爆被害の実相を語り伝え、核兵器の廃絶を訴え、皆さんと共に歩んでいきます。皆様方の国際的な活動に敬意を払い、今後の活動が大きく広がることを願っています。核兵器を作るのも使うのも私たち人間です。そして使うことを止めることができるのも、核兵器をなくすことができるのも私たちです。安心安全で希望が持てる青い地球を次世代に。ありがとうございました。
Can we move this up a little so we can see better? I just move the table so we can see. Ladies and gentlemen, I will give you a minute to just sit with your thoughts before we start the first plenary session. Okay, welcome to this first plenary session of the conference. It's a little bit difficult to refocus after this, but we will try. And the plenary session, by the theme Setting the Scene, the importance of equity for health and the role of healthcare and innovation for equity, may be a proper start for this conference and bridge from the touching words we just heard. I will be chairing this session alongside with my esteemed colleague, Professor Katsunori Kondo, whom I would like to introduce a little better than I did in the beginning. Professor Kondo, a distinguished leader in the field of social epidemiology, has made substantial contributions to our understanding of social determinants of health and their impact on aging and health inequalities. His work has been instrumental in advancing community-based approaches to health promotion, particularly in Japan and beyond, which makes his insights invaluable as we explore ways healthcare and innovation can drive equity for health. Thank you. In this session, we will hear from two renowned keynote speakers who will guide us through critical perspectives on health equity. They will address pressing questions around the role of healthcare in mitigating health disparities, the innovations that hold the potential to enhance equity, and the challenges posed by social and environmental factors. We aim to ground today's discussion in a deep understanding of why equity is not only essential for health, but foundational to building resilient healthcare system. I am delighted to share this space with you all as we open the floor to ideas and reflection that can pave the way toward a more equitable health landscape. Thank you for being here, and let us now begin. I invite our first speaker, who is Professor Fran Baum from University of Adelaide, Australia. Professor Baum is Director of Stretton Health Equity Stretton Institute, University of Adelaide. She is a Fellow of the Academy of the Social Sciences in Australia, the Australian Academy of Health and Medical Sciences, and of the Australian Health Promotion Association. She's also past National President and life member of the Public Health Association of Australia. She is the immediate past co-chair of the Global Steering Council of the People's Health Movement, a global network of health activists, and a member of the PHM Advisory Council. She is also the author of over 400 publications, including The New Public Health and Governing for Health, and she's the co-editor of the Oxford textbook of Global Public Health. Professor Baum will speak on the topic, the role of hospital and health services in promoting health equity in a troubled world. It is my honor and pleasure to welcome you to this plenary session. Welcome, Professor Baum.
Thank you so much to both chairs, and thank you also for the invitation from the organising committee to speak to you today, and also distinguished guests. It's wonderful to see so many people at a health promotion conference. What I'm going to talk about today, it's not, that's it. I'm going to first of all talk about the polycrises that are threatening health equity in the world, and then I'm going to pose 4 equity questions for health systems. The first is about how medicine works, whether it works for the greatest good. The next is about how we can finance universal care for health equity. Then I'm going to think about cultural and social safety, and then what is effective health promotion and disease prevention in our troubled world. We're facing interacting polycrises. We all know that there are crises in the world, but now I think the way that they're interacting, and I think Mrs. Kodomo has reminded us that we're at a dangerous point in the world. We've got ecological and climate crises. We're seeing increasing disasters around the world as a result of that. I don't need to say much more about war and conflict. The previous speaker did that. We've got less stable political systems with populist leaders, and I think a presidential election today has underlined that. We've got declining trust in formal politics and increasing political violence in the world. There are many social crises. Loneliness is increasing in many societies. There's less community spirit, less solidarity, more fundamentalism and racism. And of course, there's economic inequality that I'll say more about. And all of this is driving diseases in all sorts of different ways. Perhaps underpinning everything is the climate crisis. And Antonio Guterres, the Secretary General of the UN, said we're teetering on a planetary tightrope. Either leaders bridge the emissions gap or we plunge headlong into climate disaster, with the poorest and most vulnerable suffering the most. So climate change will increase health inequities. We can see in the world that the countries that are producing the most greenhouse gases and having the biggest impact on the planet are the richest countries, those that have most health anyway. So once again, that really will be increasing health inequities. In terms of war and conflict, we know that there's much more, and war doesn't just have the immediate impact on people, although as we've seen, that is just absolutely devastating, but it also creates refugee crisis. It means that we're spending valuable money that could be spent on health services. 1 in 6 people in the world are now, sorry, I need to go back. there. 1 in 6 people in the world are exposed to conflict. And we know that in Palestine, over 1,000 health workers have been killed and hospital and health services have been destroyed. So war is a real reality in the world today and is increasing health inequities. When we think about inequities, we have to think about how income and wealth are distributed. And what you see here is that the top 10% of people in the world own 76% of the wealth and over half the income. So that is a massive inequities, especially when you see that the bottom 50% only own 2% of the wealth and 8.5% of the income. So we're living with massive economic inequities, and these really translate into health inequities. I did a calculation last night that Elon Musk on the 1st of November was declared the richest person in the world with a net worth of $263 billion, and 1 billion equals 1,000 million. And I worked out that the whole public health budget for Tanzania is equivalent to 0.34% of Elon Musk's wealth. So I think that's just one example of the kind of massive economic inequities that we're living with. And of course that translates into life expectancy. We've already heard that in Australia, in Japan, there are huge disparities between people, and if we look globally, we see that too. And just about every country where we have good data, we see that health is not equally divided. And of course what this means is that we're not delivering on the SDGs, on the promise that was made that the SDGs would be achieved by 2030. We have less than 1/5 of the targets which are on track. And the World Economic Forum, which isn't the most progressive forum in the world in many ways, but it noted that inequality is the accumulation of wealth and power in a few hands. It has corrupted and polarized our politics and media. It is corroding our democracies. So inequities, and I know Richard Wilkinson, who's speaking next, will say much more about the impact of inequities on societies. A British commentator, Anthony Atkinson, made the point that the levels of economic inequality, which when he wrote that some 10 years ago were not as great, are intrinsically inconsistent with the conception of a good society. And the important thing is that inequities affect all of us, whether we're at the bottom or the middle of the, or the top of the gradient of inequities. And I think at the heart of these polycrises is an unfair global economic and political system. It's really based on extractivism and exploiting the natural environment. It results in overconsumption for many people in countries like Australia, where consumption is very high, and underconsumption if you think about those people, the 50% of the population that only control 2% of the wealth. And it's an economic system that puts profit above all else, that sees profit as more important than health. Now, I think I may have made you feel all depressed, and I found this picture from Van Gogh of despair. But then I also thought, well, what do we say for health systems? And I looked at Pablo Caladas, who said, the famous cellist, who said, the situation is hopeless. We must take the next step. So that's what I want to do for the rest of the talk, to think about, well, what are the equity questions for health-promoting health systems? What are the steps that can be taken in a world which is facing these crises? So the first of those is about the greatest good for the greatest number. Is that how we run our health systems, or is it the greatest good for the wealthiest? Tudor Hart, who was a general medical practitioner from Wales, wrote in The Lancet back in 1971, the availability of good medical care tends to vary inversely with the need for it in the population served. And he called that the inverse care law. So the people who need medical care most are the least likely to get it. And didn't we see that during the pandemic? This is a graph showing the COVID vaccines per 100 people in the early days of the pandemic in 2021. And what you see is that in low-income countries, that was down to about 4 people, whereas in high-income countries, there was more than a vaccine each. So massive, massive inequities in global distribution. If we look at public healthcare expenditure as a share of GDP, and remember GDP varies a lot in those different countries, then we can see that inverse care law in action. That if you think back to the map with life expectancy, the countries with the lowest life expectancy are also those with the lowest expenditure on healthcare. So just showing how that inverse care law. And then I think what's also happening with medicine is that maybe for some people there's too much medicine, and there's an increasing literature asking questions about low-value care, that we're spending a lot of money on low-value care, that some medical treatment is futile, especially at the end of life, that we have powerful pharmaceutical companies selling sickness, and raising a lot of questions about the sort of disease mongering, as Ray Moynihan has said. One of the roles I've got at the moment is on the International Advisory Committee of the British Medical Journal, and we're just launching a commission on the future of academic medicine. I'm one of the co-chairs of that, and we're asking those questions about how should medicine be for the future. And I'd welcome any of you to, we're inviting people to contribute pieces to the BMJ, and it would be great to have a number of contributions on promoting health services rather than just clinical papers. So that's just taking the chance to give that call out. So the next equity question is, well, is about financing universal health care for equity. And we do have choices about that. Is it public? Is it private? And if we look at this chart of OECD countries looking at life expectancy versus health expenditure, you can see what an outlier the US is, which is the most highly privatized health system. Their life expectancy is declining and is below 77 now. That compares with in Japan, where you have the highest life expectancy in the world of about 84. And just recently in a paper in the New English Journal of Medicine, Bruce and his colleagues have pointed out the impact of financialization on the health service in the US. Financialization is about the increase in a country's financial sector relevant to its overall economy. And he points out that increasingly people are investing, speculating in health and social care in order to draw shareholder value. And he pointed out that there was $70 billion profit in 2022, which was an increase of 300% in a decade in terms of people taking profit from healthcare. And he points out that these authors point out that the concern is much more with profit than with equity, and it's resulted in increasing costs for patients and an increasing number of bankruptcies. And that the biggest reason for bankruptcies in the US is healthcare expenditure. So this worrying trend of financialization is also spreading in other parts of the world, and I think it's something that we need to resist. And I think the other lesson we need to think about is that health depends on distribution, not absolute wealth. And here I've just done a comparison of Costa Rica and the US. And what you'll see from that comparison is that Costa Ricans live a little bit longer than those in the US. They spend much less per capita than the US does, only $1,700 compared to over $11,000. Their GDP is also very low, so they achieve good health at low cost. And while they do that, they emit much less carbon dioxide, so they have one of those low ecological footprints rather than the very high one like the US. And they've done that really through having fantastic primary health care, and I'll talk a bit more about primary health care in a bit. Also having high literacy rates and paying attention to a range of social determinants of health like housing and living conditions. But when we think about how we finance health services, Oxfam has made the point that we really need to stop spending development funds on for-profit private healthcare providers. They say it's not a good investment and that we need to really invest in strengthening public health systems. The chair mentioned my role in the People's Health Movement, and we have a People's Health Charter that we adopted when we were formed in the year 2000. And we call for the provision of universal and comprehensive primary health care, irrespective of people's ability to pay. So everybody should have that. And we oppose international and national policies that privatise healthcare and turn it into a commodity rather than a right. So seeing healthcare as a right, I think, is one of the most important steps a health system can make for health equity. So the next question I want to pose for health equity is, how do we make health systems culturally and socially safe for everybody? And that involves the avoidance of discrimination and stigmatization, and ensuring equity of care for everyone, whatever their orientation, their race, or their socio-economic status. I think acceptability of care is also very much tied up with the importance of citizen and community control or participation in designing healthcare and even in managing and running healthcare. There's a lot of rhetoric about community control, but when it's done well, it can result in really effective health services for populations that are often marginalised. I can give you the example of the Aboriginal community-controlled health services in Australia. There's over 140 of those services. They have a strong decolonised underpinning. Australia was obviously a colony of the UK, and that had incredibly severe health implications for the Indigenous people. That movement resulted from community demand, people saying we want health services that serve our needs. They provide culturally safe services that really are adapted to the local populations. They draw on traditional knowledges. And I do a lot of research with these services, and they're always constantly having to negotiate with the mainstream and what they perceive as ongoing colonisation. But despite that, they manage to offer fantastic health services to their local populations, and their boards of management are made up by local people. I also know in nearby Taiwan has introduced last year an Indigenous People's Health Act, which is establishing very much the same principles as the Aboriginal community-controlled health services in Australia, giving people power to dictate what kind of services make sense for them. The other thing that often stops people having good health care is obviously the social determinants of health. And some of the work we've done is looking at developing a social health screening tool that can be used by clinicians so they can determine if they're patients, the patient can fill in that tool before the consultation, looking at their housing status, their employment status, the situation at home, and their income, if they're under income stress or not. Our research has also said that cultural safety in health services needs to apply to policy, and I don't have time to go into it, but we've developed a framework to assess how culturally safe public policy is. Because if you don't have the policy being culturally safe, then it's much, much harder for the health services to be culturally safe. Okay, the final question I want to ask is how to provide prevention and health promotion for all, including tackling the commercial determinants of health that I think are becoming increasingly important. I've already mentioned the importance of primary health care, and I want to stress that for equity, I think comprehensive primary health care, which includes curative, rehabilitative, preventive, and promotive, is vital. I've just got two examples here. In terms of diabetes, obviously for the curative, it would be the best clinical care and good coordination between different disciplines, different health workers, whether it's nutritionists or nurses or doctors. Rehabilitative may involve groups for self-management of diabetes, maybe including foot care. Preventive would be working to reduce the amount of sugar and fat through education and encouraging people to take exercise, which is obviously good for their health. And promotive would be encouraging a healthy food supply, fresh food markets, taxes on high-fat, sugar foods and drinks, developing high-exercise suburbs that encourage people to walk, and building active transport into the fabric of life. So that would be a comprehensive primary healthcare approach to diabetes. If we take a problem like speech problems in children, that's that's a real issue in terms of education. The curative work would be speech pathology. Rehabilitative would be teacher and parent training. Preventive would be screening in childcare to pick up children who had speech problems. And then promotive would be promoting reading and good communication skills in early childhood and beyond, and ensuring free early childhood education for all children. Michael Marmot, who chaired the Commission on the Social Determinants of Health, really stresses that early childhood education is absolutely vital to health equity. In Australia, we found that under policies that we could describe as neoliberal, that put a focus on, in health systems, put a focus on measuring and looking very much at outputs rather than ultimate health outcomes, can undermine comprehensive primary health care. And we found that was the case in our study in Australia. We found that with budget pressures on health systems, it tends to be health promotion and disease prevention that gets cut. And that is largely because medical voices tend to be louder and supported by medical power. We also found that competitive tendering puts a focus on outputs rather than health outcomes, and that also undermined health promotion for health equity. And under these kind of public policies, community health services were transformed into intermediate care centres for chronic disease, which is of course important, but then the money for health promotion was cut. So what can we do about action on social determinants of health? Well, I think two of the most promising developments that have come out of the Ottawa Charter that we've already heard about and the Geneva Declaration is working together on health in all policies and healthy cities. And what underpins both of those is an understanding of the social determinants of health. And I was a commissioner on the Commission on Social Determinants of Health, and we concluded there that if we want to have an equitable world in terms of health, then we have to have serious action on the social determinants. And I'm sure many of you have been involved in these initiatives and know their power and importance. I think the important thing about health in all policies is that it really focuses on changing structures, not on changing individuals' behaviour directly. And this is one example from WHO, which looks at air pollution and looks at the importance of clean energy, of housing, of transport, of urban planning. You can't improve air pollution, which is a major killer of people across the world, unless you have that action across all sectors. And it's important in all of this to recognise the limitations of behavioural health promotion. In the 1970s, people tried to change behaviour directly through a range of heart health programs, for instance, and really the results were very disappointing because it was clear that people's behaviours change when the structures they live in change. And you can see here how these authors from the Netherlands have shown how individually orientated preventive action, they're looking at cardiovascular disease, can make it a really impossible uphill battle when you think about the availability of tobacco, environmental barriers to physical activity, the affordability and marketing of unhealthy food, and the common sale of alcohol, and of course socio-economic inequalities that reflect the social determinants of health. So I think it was very pleasing when Margaret Chan, when she was director of WHO, said that obesity, diabetes was not a failure of individual willpower to resist fats, sweets, or exercise. It really was about the food and soda industries and the advertising of unhealthy foods. And she said the interests of the public must be prioritised over those of corporations. So in the Lancet last year with colleagues, we defined the commercial determinants of health as the systems, practices, and pathways through which commercial actors drive health and equity. And Nick Freudenberg has written a very good book called At What Cost?, looking at capitalism and health promotion. And he lists that these public health crises of the 21st century all reflect commercial determinants of health. The pandemic, climate disasters, the rising burdens of non-communicable diseases, occupational illnesses and injuries, mental health conditions, environmental exposures to air and water pollution, and injuries and deaths from firearms. And of course, some of that is from unhealthy products. I've already talked about some of those, ultra-processed food and beverage, gambling, weapons, alcohol, the extractive industries, including fossil fuels, unsafe products, and many more. But it's also about the processes. And I want to look a bit at those and think about how commercial determinants drive climate change and how the political lobbying, which is a practice of large companies, really affects that. The PowerPoint has stuck. Yeah, that's working. If the healthcare sector were a country, it would be the 5th biggest emitter of greenhouse gases on the planet. So that's giving us a clear message about what the health sector can do and how important climate change is to health equity if you think about Antonio Guterres' point about the inequitable consequences of climate change. The WHO is leading us in terms of many guidances on climate action. The Lancet has had a commission on climate change, and there are many initiatives now to try and do something about climate change. But I'm going to use an example from my own country where the health sector has produced a national health and climate strategy. That's pretty good. It mentions health in all policies. But look at how we're using our carbon budget. We're not doing well. We're online to keep using carbon at a rate that will be beyond warming at 2%, that will result in all sorts of catastrophes like the one we saw in Spain with the floods last year. And a number of commentators have said, well, that happens in Australia because of the lobbying and revolving door between fossil fuel companies and the government. And here's 2 books that say that. The latest one is Slick, Australia's Toxic Relationship with Big Oil, and another one called The Carbon Club. So what can a health sector do about these very powerful players, the commercial determinants of health? Well, obviously, you can point out the damage. We can also put our own house in order by creating green health systems, and around the world more and more health systems are doing that, as I pointed in Australia. We can warn of the health dangers of climate change. But I also think that health professionals can be very powerful advocates, and I just want to end by looking at that. Taxation, I think, is a big health issue, because if we were able to have fairer taxation, then we'd have much more resources to make fair and equitable health systems. So I think advocacy in terms of taxation for health is really important. Arguing for progressive taxation, perhaps a financial transaction tax, a global tax on capital, and closing loopholes for transnational corporations and the mega-rich. And I think we also need campaigns to argue for the public good value of tax, because it's tax that funds our health system, funds our security systems. And another example of advocacy is from Darwin in the Northern Territory, where a large supermarket chain, Woolworths, was going to open a large liquor store, alcohol store, near an Indigenous community that already suffered from alcohol harms. And the local health service advocated strongly against that and was successful in getting the supermarket chain to abandon that alcohol outlet. There are also many examples of doctors working for fossil fuel reduction, and nurses as well, climate action for nurses. Other examples are doctors against vaping, health professionals ending gun violence in the US, and doctors calling for a crackdown on junk food, because we know how much that fuels ill health. And the final thing that I think health systems can do is to support and strengthen community and citizen engagement. I think Mrs. Kamado has just shown us how powerful it can be to hear from people who have direct experience. There's nothing like that lived experience. And yet around the world we're seeing crackdowns on civil society and its environmental NGOs, and people are saying civil society is at risk, civil space is at risk. And I think health, what is very powerful in changing policy is having that top-down action from politicians and senior policymakers, but also having that community action. And I know some of our community health centres in Australia really support the community to make their voice heard. So I think that's something that health systems can do. And as I said, I can't leave that topic without talking about the People's Health Movement, which really is a strong voice for people's health globally and is in all sorts of forums, including the World Health Assembly, where it always runs a World Assembly Health Watch, looking at the debates that are happening at the World Health Assembly. So, I hope I haven't left you all depressed, because the world is facing polycrisis. And I just wanted to read this quote. Clarissa Estes said, "Ours is not the task of fixing the entire world all at once, but of stretching out to mend the part of the world that is within our reach. It is not given to us to know which acts or by whom will cause the critical mass to tip towards an enduring good." And that's, of course, what we all want. So despite the polycrisis and an increasingly unstable world, I do think health-promoting hospitals and health systems can be a force for hope and a focus of the fight for a more sustainable, healthy and equitable world. And I'm sure you will all be engaging in that fight. Thank you.
Professor Baum, please don't leave it that quickly. We will not open the floor for questions, but I want to thank you very much for this very comprehensive presentation. And actually, you've introduced a new term in my vocabulary, maybe not in the audience, but in mine. We've heard of determinants of health and social determinants of health, but you've introduced commercial determinants of health that I will have to learn more about, so thank you for that. But you have also given us, I think you have given us hope, not only to feel bad about this, but you've given us a number of challenges to turn the development toward a more equitable health. You've talked about healthcare for the greater mass or for the wealthiest, economy financing, culture and socially safe, and providing health promotion and prevention to all. You've also addressed several policy areas that we need to work with. With all this, what, in your opinion, would be the most important challenge or area to start with?
Well, I think because we're reaching planetary limits, it has to be climate change. If we don't solve climate change, then the other problems... But unfortunately, the pressures of climate change are fueling the war and conflict, fueling the inequities. But unless we can find a way to stop global warming, the future is bleak for the planet.
Okay. Thank you very much again.
I would like to introduce the next speaker, who is special in particular to me. Though I am one of the pioneers of research in the field of social epidemiology in Japan, if I had not read his book, Unhealthy Society in the UK 25 years ago, I would not become social epidemiologist, and I might not be here. The special speaker is Professor Emeritus Richard Wilkinson. Please. We can't hear.
Okay.
Okay.
I'm sorry. I was saying it's such an honor to speak to you in Hiroshima, and I was so glad I heard the speaker earlier describing the events, the bomb, and I do think that. And my mother had a Japanese friend who was only alive because she missed her train into Hiroshima that morning. She worked in Hiroshima, but survived because she missed her train. And I remember her as when I was a child, I remember her staying with us. We always used to go on the demonstrations against nuclear weapons, and I think we must redouble our efforts. I'm so glad to be reminded of the importance of those issues because I think that the world is in such a dangerous situation. I'd like to go on, though, to thank Fran Baum. I support all that she said. I thought her talk was brilliant and really important. It covers so many things that I'm not going to touch on at all. I want to, I suppose, start. I'm going to share my slides. Now, that one and that one and that one. Can you see my slides?
Yes.
Good. I want to start, though, with this one, just as an explanation why I'm not with you today. I wish I could be, but I decided some time ago not to fly because of the environmental impact. This slide along the horizontal axis shows each month of the year, and the lower lines are the earlier years from 1940 to 2024. And at the top, the yellow line and the red line show how much more rapid global heating has been recently. It seems to be accelerating. And I think the climate scientists are now really frightened of what is happening. And we must take it seriously. So that is why I'm doing this online rather than being with you today. I want, before getting into my main talk, to point up another issue that I think is of central importance. I was looking at the American government's official data on substance abuse, drug abuse, and mental health and mental disorders. The figures exclude recreational drug use, even if they're legal drugs, and they're included as cases, whether mental illness or drug abuse, only when they impair people's relationships, their health, or their ability to carry out their normal responsibilities with family and work. On that basis, the people in the United States for whom these problems are really messing up their lives, 85 million adults. That's more than 10 times the population of New York, the city itself, over 4 times the population of the larger New York metropolitan area. All our cities all our countries in the affluent world have high levels of these problems. And of course, when there are news items about rates of these issues, mental health, drug abuse, particularly amongst children, the demand is always for more services. We don't stop to ask, why on earth are our societies producing this scale of mental health and drug problems? So I want that to be a sort of background issue in what I have to say. I'm going to talk about income inequality. I think I mean also wealth inequality, the material inequalities between us, but the data I use is on income differences in a population. I want you to think of that as a social relationship, putting us one above the other in a society, from what seems to be superior to inferior, and all the problems that that creates, feelings of superiority and inferiority, dominance and subordination, how it increases the social status competition status consumption of goods, and our anxieties about self-worth. It increases the idea that some people are worth so much more than others. So when I talk about income inequality, don't just think of material circumstances. Think about where it places you in the social hierarchy and the implications of that for respect and disrespect, all those issues. We became aware, really, of how important social status is itself through the work of people working on non-human primates, on macaque monkeys and baboons. And I think we'd always thought, working on health inequalities, that the classification systems we were using were really proxies for the real material factors, real material causes of health inequalities that lay behind that. It was only through the work of people like Carol Shively and Robert Sapolsky we became aware that social status itself, low social status, is an important risk factor for health. Carol Shively there had a troop of macaque monkeys in captivity. She could keep them in the same compounds, give them the same food, and she could even manipulate social status by moving animals into different groups. Under those circumstances, she found still the subordinate animals, the coronary arteries were getting furred up. She's pointing to the artery of a low status macaque monkey. On the left in that picture on her screen is the clear artery of a dominant animal. And Robert Sapolsky, studying troops of baboons in the wild, was finding results related to social status, which were remarkably similar in many ways to what we are finding amongst human beings. So don't think of social status as mattering only because of the differences in material standards. It's also how you're seen and respected and disrespected. We put together in an earlier book data on a whole range of important problems: life expectancy, maths and literacy scores of children internationally, infant mortality rates, homicide rates, proportion of the population in prison, teenage birth rates, levels of trust, how much people feel they can trust others, obesity rates, mental illness, which includes drug and alcohol addiction, and some figures on social mobility. We weighted them all equally, and where a country is simply its sort of average performance on those things. Bad scores are scored high, and so the countries on the right are doing worse. Along the bottom, you have income inequality. So the more unequal countries tend to do worse on a whole range of problems like that. And if you, we've recently updated the data after 15 years from the previous one, and the picture looks remarkably similar. If you look at measures of child well-being, quite different measure. This is a measure which contains about 40 different components designed to measure child well-being in rich countries. You see more unequal countries on the right doing badly. In this one, bad scores are scored low, so it slopes the other way. But exactly the same picture. More unequal countries doing badly on this collection of measures. The components of that are things like child immunization rates, whether children are bullied at school, drug abuse, whether children feel they can talk to their parents, things like that all go into this measure. And so whichever of these you look at, more unequal countries doing badly. I want now to take you to what I think is the center of the damage that inequality does. Sorry, in this slide, I think people have intuited that inequality is damaging to social cohesion. It's socially corrosive. I regard inequality as a psychological stressor. But what this graph shows is people's participation in community life falls away. There are now quite a number of studies that show this relationship. The more unequal a country is, the less likely it is that people are involved in community life, less likely to know their neighbors, and so on. They're also less likely to trust each other. The measure here is the proportion of the population who agree that most people can be trusted. And you see it varies amongst the more unequal countries. Perhaps 20% of the population feel they can trust others. In more equal countries, it's maybe 70%, 65 or 70% of the population feel they can trust others. And if you're walking home late at night in a big city, you'll feel much safer in a more equal country. There are also many, many studies of violence. I should think there are probably more than 60 by now, showing that violence tends to be more common in more unequal societies. These red dots are American states, and the blue triangles are Canadian provinces. And again, you see the differences in the scale of violence. This is homicides per million people, is enormous. It goes from about 15 homicides per million up to 150. When we wrote our spirit level book, looked not only at the rich developed countries, but also as a separate test bed, the 50 American states, finding these relationships in both settings. If you look at very much more unequal countries, you find that it's gone a whole stage further. Instead of just people not trusting each other or having weaker community life, they're frightened of each other. This is Mexico, one of the most unequal countries in the world. And you can see they barricade their windows and doors and put their fences, and there's razor wire around the top. They advise you not to go out in the evening because it's too dangerous. If you look at South Africa, another extraordinarily unequal society, you find just the same. That notice warns you that if you're caught climbing in, you might get shot. The wires at the top are, of course, an electric fence. And if by any chance you did get in, there are two great big dogs, I'm sorry, it's out of focus, who would presumably deal with you. What is so awful about this is that if you look at studies of happiness, health, well-being, you find that the quality of social relations is absolutely crucial. The number of friends people have, the quality of their relationships, whether they're involved in community life, a really important determinant of health and a really important determinant of happiness and other measures of well-being. And so what inequality is doing is destroying the center, in a way, the center of our quality of life, the real subjective quality of our lives. Some American economists showed, in a way, I suppose, the cost of this. Um, as community life breaks down and people trust each other less, we use more of what they called guard labor. That is security staff, prison officers, police, all the people we use, if you like, to protect ourselves from each other. That becomes an increasing proportion of the labor force uh, as income differences get bigger. I think what we're dealing with is not a sort of separate influence on well-being, health and well-being from what we've always known about. What we're, in a way, understanding is more about the social gradient in health. Whether our societies are very steep social pyramid like that or much shallower one. I think that in a way we should see the material differences between us, the material differences that divide us, as creating the social distances between us. And it's that is damaging. And I think what I've been looking at really is the tendency for all the problems that have social gradients, all the problems like poor education, poor health, violence, to be worse at the bottom of society in the poorest areas. And what income inequality does is to make those problems worse. The only surprise is that it doesn't just make it worse amongst the poor. The biggest effects on the poor, but there seem to be smaller differences caused by inequality further up the scale. So even middle class people would probably do better on a number of counts if they lived in a more equal country. I want now just to say a little bit about the effects of poverty. I want to read you a paragraph or two from a study of poverty in a lot of different countries. Robert Walker and colleagues did a study interviewing people in poverty in Uganda, in India, in China, Pakistan, South Korea, my country, the United Kingdom, and Norway. And of course, poverty means quite different things in those rich and poor countries. In the worst cases, poverty means something like this picture on the right. In a rich country like Norway, it means something like the picture on the left. A 2 or 3 bedroom flat with central heating, probably most of the modern electronics. But when they interviewed people about the experience of poverty, this is what they said. This is simply reading from their study. Respondents universally despised poverty and frequently despised themselves for being poor. Parents were often despised by their children, women despised their menfolk, and some men were reported to take out their self-loathing on their partners and children, despite generally believing that they had done their best against all odds. They mostly considered that they had both failed themselves by being poor and that others saw them as failures. This internalization of shame was further externally reinforced in the family, the workplace, and their dealings with officials. Even children couldn't escape this shaming, for with the possible exception of Pakistan, school was an engine of social grading, a place of humiliation for those without the possessions that guaranteed social acceptance. So again, when you think of poverty, don't forget the very powerful psychosocial stressors of being at the bottom, of feeling looked down on and disrespected. It's crucially important. When we were first aware that stress had important impacts on health. Um, we didn't know what were the most important causes of stress in society. And of course, as we started to think about it, we thought maybe losing your job or losing your house. But actually, at the level of the whole population, those things are not so common. Um, if you're thinking of stress amongst whole populations, then these worries about how others see and judge you um, are more important as sources of stress. And there are now studies which show that that sort of anxiety about how you're seen and judged, here called status anxiety, is higher in all income groups in more unequal countries. Along the bottom, you have the deciles of the income distribution. So the poorest on the left and the richest on the right. The top line is the higher levels of status anxiety, those worries about how you're seen and judged by others. And at the bottom is the low inequality societies, the more equal societies with lower levels of worrying about status and so on. So I think when we think about social stresses, we need to think of these as perhaps the most important in our society and to understand how they are exacerbated by bigger material differences between us. We know that actually these kinds of worries are the most powerful causes of high levels of cortisol, the biological stress responses. In the study, a review paper of, I think, 208 studies looking at stress responses when people were given stressful tasks to do, they found that the tasks which most reliably raised stress hormones were tasks that included what they called social evaluative threats to self-esteem and yes, situations where you could be judged negatively. So the reason why people regard public speaking as stressful is you're afraid of making a fool of yourself, of looking silly. Other kinds of stressors were less important, had a small effect on stress hormones. We know that also, and I started off with environmental things, but we also know that because of these worries about how you're seen and judged, people try and improve how they appear to others. And so in more unequal societies, people spend more money on status goods, on expensive cars or clothes with the right designer labels. So worries about status, those inequalities lead to more of that conspicuous consumption and consumerism that is so bad for the environment. It's also bad for mental illness and contributes to those figures that I showed you, for instance, for the United States right at the beginning. Sherry Johnson here at Berkeley and her colleagues showed that actually a number of mental illnesses and personality disorders are triggered or exacerbated by social hierarchy, those issues to do with dominance and subordination. And there are now a number of papers that show that in more unequal countries, mental illnesses tend to be worse. Sorry, I've lost that. Where is it? Yes, this is a study in the British Medical Journal Open a few years ago, which shows amongst the 36 OECD countries, the levels of, what is it, 9 different mental health problems. And the length of the blue line is the correlation coefficient with inequality. So you can see in more unequal countries, there are more of those psychological problems. Suicide and alcohol, a little bit the other way, but I think not significantly. If you're worried about how you're seen and judged, the social evaluative threat is what psychologists call it. If the social evaluative threat is higher, there are two responses. You might accept that you're worthless, you're no good at anything. You worry about how people will judge you, and start and perhaps find any social meeting quite difficult. And so you avoid going to parties, you avoid going out in the evening, you withdraw from social life and probably get depressed. But the other response is like this. It's to flaunt your abilities and talents and successes and so on, to become narcissistic. Perhaps like the man who's just won the election in the United States. We know that this kind of self-advertisement, self-enhancement increases in more unequal countries. In this study, people in different countries are asked how they'd rate themselves compared to others in their own society. And the proportion who think they're better than others increases with inequality. It's a form of self-advertisement. But I want just to remind you that we haven't always lived in hierarchies. The evidence is that the vast majority of the hunting and gathering societies of our prehistory were highly egalitarian, based themselves on gift exchange and sharing. And indeed, Marshall Sahlins, a wonderful anthropologist who died a couple of years ago, who studied those societies all his life, well, all his career, said gifts make friends and friends make gifts. You see the problems of competition for resources and the way gifts are a symbol of friendship because they're a recognition of your need. I'm not going to fight for access to necessities. I'm going to share. And in our language, this is deeply embedded. I would like to know in Japanese, but in several European languages, our word for companion, our friends, are the people we share the basic necessities with. It combines com and pan together and bread. So thank you very much.
Thank you very much, Richard. Thank you for your inspiring lecture, like your book. I have one question. Recently, there has been a movement to focus not only on health, but also on well-being. WHO also published the Geneva Charter for Well-being as the 10th Global Conference on Health Promotion in 2021. I would like to know your thoughts on the significance of expanding the focus to well-being rather than just on the health inequality.
Well, I suppose it goes right back to my training in epidemiology, where we saw that the World Health Organization's definition of health was a state of complete physical, mental, and social well-being, not only the absence of disease and infirmity. And I think if you can see the causes of disease still widespread in our societies, you can't talk about a healthy society just in terms of the end result, if you see that the society is still working in a way, as Fran said in her talk, to produce ill health, that is part of the picture that we can't leave out. And that is why I started with those very striking figures from the United States. And, you know, our societies all have extraordinarily high levels of stress, mental illness, and drug problems, alcohol addiction, and so on, which I suspect a very important part of them all is that they are responses to stress. And I do regard inequality as a social stressor. So I think just to look at disease, health is defined narrowly, is only to look at part of the picture.
Thank you very much for your wonderful lecture. Please, big hand for Richard.
And thank you all for participating in this afternoon's session. We apologize, of course, for running a bit late, but I hope most of you had an inspiring afternoon. And I think that we all can bring something with us home today that we can tell our children and grandchildren. So now I would like to invite you, I think I will invite you anyway, to the welcome reception and take a chance to meet with colleagues from all over the world who, just like you, are devoted to health promotion and health equity, and now also well-being. Welcome.
Next venue is Himawari and Dahlia 1 and 2. Please move to the next venue. It is on the second basement level.
Okay.
Oh, thank you.
Thank you. It was very, very nice. Yes.
次の今言った言うつもりだったらじゃあもう一回アナウンスする日本語で
お疲れ様です。日本の皆さんにお伝えします。レセプションは地下2階のひまわりとダリアという会場でやりますので、すぐにご移動をお願いできますでしょうか。皆さん集まり次第順次始めていきますのでよろしくお願いいたします。